Hi, good morning, everyone. Welcome on 129th CMAAO weekly session. This session is a new series where we have a new incoming president from Pakistan Medical Association. Before we start the session, I welcome Dr. Wazir Qazi, who has taken over as a president for CMAAO. I would like to invite him for his inaugural speech and give us an update what happened last week in CMAAO General Assembly. Dr. Wazir, congratulations, and the floor is yours.
Thank you very much, Sarab, and very warm welcome to all the participants present here today. And we had a wonderful Council and General Assembly meeting at Karachi. It was held at the Pearl Continental Hotel, and some of the delegates arrived early, and they had a good city tour as well. Chong and Angelique Kwedzi from South Africa. After from South Africa, they arrived earlier, and they came as observer for the CMAAO General Assembly. Apart from being observer, they were invited speakers for a parallel meeting of CMAAO PMA Joint Medical Conference, where they presented excellent papers. Dr. Chong also arrived 2 days earlier, and it was wonderful to see him there at the General Assembly. Then a delegation of Malaysia, led by Karchai, who is the Vice Consul Chair as well, they also, were present physically. So this was basically a hybrid meeting wherein we had in-person participants and then online participants. And it was conducted and ran by the Secretary General Imamura from Japan, and all the online participants were there. And the meeting started with the council meeting, and everybody was there, and it was uninterrupted online meeting, and the running was very smooth. Chong, as chair of the council, was there, and important decisions and presentations were made. And we had Secretary General of WMA also sent his message, video message, and that was played there. Then after the council meeting, we had the ceremonial, meeting, and wherein I was installed as president of CMAAO for the year 2022-2023. And since our outgoing president, Chiu, could not make it physically, so he was there live from Taiwan. And on behalf of President Chiu, Dr. Chong, presented me the presidential medal. And then the decisions at the council meeting, wherein all the reports, by treasurer, by secretary general, were presented. And Elvin was there, and then these decisions were endorsed by the General Assembly as well. And the next meeting venue and the meeting was decided, and the next meeting will be in Dhaka, Bangladesh, and the president-elect is going to be Mustafa Jalal Mohiuddin, and hopefully by that time, we'll all be attending in-person Dhaka meeting. Anyway, it was wonderful event, and we had really enjoyed the company of all the CMAAO delegates who were there in person. And it was nice to have other medical associations online live there. And I think everybody had real good time, and the rest, I think the delegates and the participants who were there, they have been sharing their good experiences, carrying back sweet memories. And all in all, it was a wonderful meeting. Thank you, Saurabh. I think that was the brief resume of our meeting at Karachi, which was held on from 23rd to 25th September.
Thank you, Dr.
Dr. Qazi, kindly, I just remind you, kindly inform about the resolution which is being passed in our
Karachi statement that will be placed over there on the website. Everybody, I think, knows that after the meeting, there's a resolution which comes as we had one in Taipei statement. Similarly, we have a Karachi statement which will be placed on the website of CMAAO, and everybody can see that. It was wonderful.
Thank you. And just to add, CMAAO is an association of many Asian countries over here. And just to name in this meeting, it's Australia, Bangladesh, Cambodia, Hong Kong, China, India, Korea, Japan, Macau, Malaysia, Myanmar, New Zealand, Pakistan, Philippines, Singapore, Sri Lanka, Taiwan, Thailand. And we have also been joined by many other non-Asian countries, which are we have seen people from Canada, US, UK, Brazil, South Africa, Sweden. So these are the regular participants which have come as an observer as well. So congratulations, Dr. Wazid.
Two of our Brazilian friends, they came all the way, traveled a long distance, and we are really thankful to them. And it was wonderful to have them.
Okay.
Giancarlo was there along with Carlo. Okay. So all in all, it was fantastic.
Thank you so much. Congratulations once again from the entire CMAAO team. And now moving forward, I would like to invite Dr. Monica Vasudev to invite the speaker for the day. Dr. Monica Vasudev has been with us over a period of time, giving us knowledge, and all the way at this hour, So Dr. Monica, can you please invite the speaker for the day?
It would be my pleasure. Thank you so much. And again, congratulations, Dr. Qazi, for taking on as the new president of CMAAO. Thank you, Saurabh, for giving me this opportunity to introduce such an amazing speaker. So please bear with me, because I want to share in detail everything that I know about her, and I think it is worth saying. So Dr. Pragya Dhruv Yadav is a senior scientist, head of the Biosafety Level 4 Laboratory, Asia's first state-of-the-art facility to handle high-risk pathogens at ICMR NIV Pune. During the pandemic, she was involved in the timely diagnostic support and development of point-of-care assays, anti-SARS human IgG antibody ELISAs, which is used widely in the country for diagnosis and transfer to 7 companies. At first, the first 3 COVID-19 cases were identified from Kerala, having travel history from Wuhan, and further genomic surveillance was initiated. She has contributed significantly to shaping India's response to the SARS-CoV pandemic by early isolation of SARS-CoV-2, its variants, and fast-tracking the development of the indigenous vaccine and demonstrating the efficacy of Covaxin against the different SARS-CoV-2 variants. I'm just going to stop here for a second to say you are more than welcome to come back to this forum to share your knowledge on other topics as well. Besides this, she has discovered many novel viruses and quickly provided diagnosis and helped in containment responses for Nipah, Zika, CCHF, KFD, and monkeypox virus outbreaks in the country. She's developed and discovered many etiological agents such as the Crimean Congo hemorrhagic fever, Nipah, Zika, Tioman, Oya, Malsur, Katki, and the equine encephalosis and Kundal virus for the first time in India. So significant virology background. She has developed many cost-effective diagnostic assays. Her work has contributed to the beginning of research in highly infectious viral pathogens that has helped the prevention and control of outbreaks in India. She is a WHO consultant in the evaluation and validation of biosafety level 3 laboratories in Nepal and Bhutan. She is a recipient of many awards. Amongst them are the Bharat Bhagya Vidyartha Samman 2022 Ministry of Culture, Government of India, and ICMR awards, just to name a few. She has published 275 research papers in national and international journals with an impact factor of 2630.34 and with 6,158 citations. We look so forward to what you have to say today, and welcome to our forum.
Thank you so much, Monica, for a very nice introduction and very kind words from you. Today I have some sore throat, so just please bear with me. In Pune, the weather is a little colder than it is actually in this time. So, I'm going to talk some of the experience which India has during the monkeypox outbreak, which is going globally, and the cases are declining. But prior to this, we all remember that we are going through a pandemic, which is still not over. The picture which I'm sharing on the screen, I hope this is visible properly to everyone. So this is a BSL-4 facility at National Institute of Virology, Pune, which is Premier Institute of Indian Council of Medical Research. And these are the teams working in BSL-3 and BSL-4 setup. As we all know that every health emergencies come with fear, anxiety, and there are 9 priority diseases has been decided by World Health Organization. Name of them, COVID is one of them, which we are going through. This CCHF, Ebola, Lassa, MERS coronavirus, Nipah, Rift Valley fever, Zika, and many of these diseases are present in the country which is attending today this meeting. And whenever there is a new disease come, that create a lot of fear, anxiety to public health and also to the community. So in this situation, what the matter, the first, how early we can diagnose or detect the disease if it is unknown, and then that can help in early containment and mitigation, which not only save the life, but also protect the economy for which we have seen happen during the pandemic. If we remember some of the humanitarian crises of 20th century, we must remember 1918 Spanish flu, 1957 Asian flu, and 1968 Hong Kong flu. With this, we also saw many civil unrest and drought in many countries. We have seen the West African outbreak of Ebola, which affected many countries, huge number of deaths, and Zika, that again a cause which actually affected millions of the people. And now we are suffering with COVID pandemic. During COVID pandemic, which affected not only the livelihood, human health, governance, security, social system, and economic system, but the challenges of variant concern also give a lot of loopholes to the vaccine program. Mass immunizations, vaccine hesitancies were all generated, and it actually challenges scientists and public health authority across the world. Today, we have around 61.7 crore cases in the world and a huge number of deaths, and that also include India is also having a large proportion of the cases and death as well. During the pandemic, when we were dealing with this with deadly disease which affected every country's economy, we also faced many other viral diseases, including CCHF, Nipah, Zika. India reported its first avian influenza cases, and then monkeypox. And recently, we are seeing the Ebola outbreak, which is going in Uganda and current strain in Sudan. So the initially Ebola vaccine, which was made for Ebola gyre, now there is a new trial going on if the existing vaccine is working with the current outbreak. The number of cases are increasing, and now a new case has been detected in bordering country. So what I'm trying to say here that different viral diseases have challenged in this century to the humankind, and they are emerging day by day. And we know the reason, because we are disturbing the wildlife, and that's how the One Health is getting affected. When we talk about the monkeypox, we have to first remember the smallpox, and the country which we have just listed under the CMAAO. Actually, many of they have gone through the suffering of smallpox, one of the disease which come under the family poxviridae, genus orthopox viruses, and has caused it is existed around 3,000 years, and had suffering to many countries, caused a huge number of deaths. And as per the record, the disease was appeared in China in 4th century, India in 7th century, and slowly it went in Asia and spread to many other countries. With a 33% of mortality, the disease caused much of the mortality, morbidity across the world. And in 1980, finally, it was declared, the word was declared smallpox free. And if we look at the phylogenetic tree, which represent different pox viruses, at the tip we can see with the red monkeypox viruses, and then it has linkage with vaccinia virus. Here in the green, variola virus, and rest of the pox virus exist in different animal and human being. The smallpox virus, which was prevalent in the past in many countries, including India, Pakistan, Bangladesh, China, and many countries, and which passed from one generation to another, and had a big challenge across the world. And it took the thanks to the vaccination and Pasteur Jenner, who actually came up with the vaccine. So the transmission of smallpox, which was recorded in the past, was mainly human to human and direct contact with infected body fluid. So these were there was no known source or host known how the virus must be evolved or affected the human being. But yes, there is some record which speak about, based on the history, how the disease is spread from one country to another. And in 18th century, it reached to the Great Britain, and then to Australia. So there is a huge history of the smallpox. And if you look at this map, which show that in 86, there was a very small portion of the people, countries affected, and then 1920 it spread. So as much the trade and the rest of the things, modernization improved, the disease also spread. And in 1926, India was one of the very high endemic country and contributed a huge proportion of the cases in the world. Finally, in 1977, due to a large vaccination program from World Health Organization and every country's great support and implementation, we could see the smallpox eradication was happening. And in India, in the last case was reported in Bangladesh, and after that we were declared as a free of smallpox. So when we talk about the eradication of smallpox, the great role was played by the vaccine which was made against the smallpox, and the first to fourth generation of the vaccine was made for smallpox. The second generation vaccine, which was approved for 18 to 64, used by bifurcated needle for a very long time, and which is also approved in USA. Then later on, further the vaccine was enhanced, and it was further used by bifurcated needle. The third generation vaccine, which later on developed, and it is being used in USA, Japan, and many other countries. They are produced by Bavarian Nordic, that is, and the second vaccine is made by KM Biologicals. These are now given by needles syringe, but the third generation LC16 is still given by bifurcated needles. They are better and improved vaccine and given to the adult population. The later on, these vaccines has also shown a better efficacy and lower side effect. So I'm just giving some of these backgrounds, because when we talk about the monkeypox, these are the essential things which everybody discussed when the monkeypox outbreak happened. So even some of the preclinical studies has shown 100% protection with Ankara strain of vaccinia multiple times, which was passaged in chick fibroblast culture to make the Bavarian Nordic vaccine, which is being not even given for the pre-exposure, but also post-exposure vaccine. The fourth generation vaccine is developed by Russia by doing a genetically engineering vaccine with the deletion and insertion, and that has shown a very high, excellent safety and efficacy. At the moment in USA and many countries, these two vaccines has been used, approved by FDA and used in prevalent countries. And the first vaccine is called Imvanex, and second one is ACAM 2000, which is licensed and used across. But most of the countries, Asian countries, do not have access to these vaccines. One of the study from CDC has shown the data that if you are vaccinated, the risk of monkeypox get 14 times reductions. And they have come up with the data that those people who is unvaccinated, the chance of getting monkeypox positivity was very high in compared to those who were vaccinated with 1 dose or 2 dose vaccine as per the vaccine type. So when we talk about the monkeypox, why everybody bothered now? Because monkeypox was always considered disease of only 11 countries in Western Africa and Central Africa. And many of the countries only reported imported cases out in these, which you can see in the blue color, and the orange color is shown those the virus where it was present. The virus was called even South African strain and Congo strain based on their location of presence. In the past, there was some antiviral which was developed for antivirals are also effective for monkeypox, but again the access and availability is a challenge for many of the country in the world. In the past, when the first outbreaks were recorded during 70 to 79, as we all know, the first case was recorded in 1970 in a child, and then there was a number of the outbreaks were recorded in these countries, and the highest mortality and highest morbidity was seen in the children and also in the females, which we are not seeing in the current outbreak. So in the past, the pattern of the disease was different, which we are seeing. And out of these 11 countries, the imported cases have been recorded. In USA in 2003, there was importation of animal, and from animal there was outbreak. And then further, there was single imported cases were reported in 21 and 22. That was the cluster of the cases. Israel has reported imported case in 18. Singapore and UK also reported in 18, 2019, 21. And the first cases of this particular outbreak, which is going on, reported from UK in May 22, and that has initiated outbreak across the world. If we talk about the reservoir of infections, some of these animals, including squirrel, dormouse, and rat and mang-bay was cause responsible. Monkeypox is a zoonotic disease, and it was always believed that it was transmitted from animal to human. But in the past, there was also observed the transmission of monkeypox virus in prairie dogs, which was noticed in USA in captive primates in Europe and other animals as well. So this is a case of 2003 monkeypox transmission, where animal to human in a non-country outbreak was recorded. And this outbreak happened because animal was kept and that infected the rest of the animal. And human and 69 people were infected in United States. With a very quick actions, the outbreak could stop. But this was the first recorded outside of these 11 countries, non-envy countries, these outbreak. So there is a question, there is a possibility of reverse zoonosis from human to animal transmission. And in a recent episode, the paper published in Lancet, it has shown that from infected human, there was a dog in the same house and that was infected. It showed all the symptoms and even the blisters, and the samples were positive. Sequencing was done and it shows exactly the same sequence which was having to the person staying with the dog. So these are certain questions which came during this outbreak. There was a lot of also question if it is a sexually transmitted because the cases which happened in UK initially, for a long time, actually, there was a question mark how the infection is spreading. And then people could link to the place where there was a gathering of a gay population, and then they could track epidemiological that the transmission was happening from men to men who are having sex individually or in with the different partners. In the past, the infection was always believed animal to human transmission, and from a mother to child, or a pregnant mother to the fetus. And these were some of the examples which I have seen here. There was also the monkeypox virus can also stay longer on the surfaces, and it has even shown study virus in environment conditions. This shows actually high individual risk, low community risk, because most of the transmission happen skin to skin or by very close contacts. In one of the study of the 4 pregnant women in the past in Africa, one gave birth to a healthy infant, 2 had miscarriage in the first trimester, and 1 had a fetal death with the stillborn showing diffuse cutaneous maculopapular skin lesions involving the head, trunk, and also palm of hand and sole of. So these kind of outcomes have been reported in some of the cases. Recently, there was also shown presence of virus in the semen, and even virus isolation, live virus isolation was shown in few of the cases. Long-term positivity of semen was also recorded in few of the cases. So that's how this question kept people kept asking if it is happening through the STI from the sexual context and all these things. But still, so far, in spite of presence of the virus in semen, it is not proven if it is sexually transmitted. But yes, it is very well established that very close contact, skin to skin contact is responsible for the transmission in the currently. So this is a recent map which I pick up from CDC sites, which show that till 29 September, we have around 68,000 cases and 27 deaths. And India also reported one of the deaths so far from Kerala in a imported case from UAE. If we talk about this virus genome, it is a DNA virus, and which has one of the highest genome, which is 197 kilobase. The cowpox virus is 220 kilobase. So it has a very huge genome, and coding and understanding the mutations are very, very difficult, because you cannot easily do a laboratory study, even as we did in the SARS coronavirus, that you can tweak some of the spike genes and you can look at the impact, how the virus is mutating, what is happening to that. And moreover, the DNA viruses are considered to be sturdy, and they, because of their proofreading, they're considered to be very stable, which again was challenged in the recent outbreak, which is going in this current outbreak. So if we talk about the diagnosis of disease, because it is a DNA virus, so polymerase chain reaction will be the best method, and which is abundantly available across the world. Because of the pandemic, people have a huge number of laboratory, and now they have facilities, infrastructure. But with this, the sequencing, now people are, because in pandemic, everybody realized the genome sequencing importance, and people are also monitoring the mutations happening in this virus. The virus isolation, where you grow the virus using the clinical sample in an artificial medium on a fixed cells, is one of the very good method, and it is very easily isolated virus. And electron microscopy is one of the oldest tool and also used for smallpox identification. In India, as soon as we realize that monkeypox virus is emerging and we need to have the laboratory, in India, we have laboratories network created by Indian Council of Medical Research. It's called Department of Health Research, Government of India. Under that, we have more than 200 laboratories across the country, and they do all kind of virus research and virus testing. So out of those, according to geographical areas, 30 of the laboratories were chosen, and in phase-wise manner. Before even we detect the first case from India, they were trained. The phase 1 included those who are very close to the international airports. 15 VRDLs were trained, and then phase 2 and phase 3. So now we have 30 laboratories across the country who can test on any referral samples. With this, we also accepted the request from World Health Organization for training the SEER member state and sending them reagents, not only for the monkeypox, but where the request was made for varicella zoster and herpes as well. And these laboratories also become functional for testing such infected samples. We also provided support if the samples were referred from some of the countries to India, because we are WHO collaborating centers for emerging infectious disease, and we sent report quickly on a very high level. So initially, when there was a challenge to get the positive controls and then speeding up our reagents, so we managed to very quickly. And I am going to share some of the work which we did here on this monkeypox virus. So after the preparedness was done, the laboratories were trained and they were shared with the reagents. At the same time, Ministry of Health from India, it released the guideline, and it actually sensitized each state, also sensitized their healthcare workers, hospitals, if such kind of any referral cases are coming, what to do, where to refer, what kind of precautionary measures to be taken. And because of the COVID pandemic preparedness, people are quite well aware what to do when such infected person come to hospital. And after that, so far, India has detected 18 monkeypox cases. The first case was detected on 14th July, and the last case was detected on 28th September. So we also carried out the genomic sequencing and virus isolation, which enhance our capacity to do more research in this virus. If we look at the old picture of a presentation of monkeypox, which show a huge number of lesions on the body of the child, but in the recent outbreak, which is going in different countries, the picture is not the same. The picture is changed, the presentation is changed, and actually that's how the role of clinicians come to identify such cases. But at the same time, this is the season in Asia, especially in the Asian countries, we are also seeing similar kind of patterns of presentation of measles, varicella zoster, and also herpes, and that panic create a lot of confusion, and most of the referral come for monkeypox actually turn out to be positive for varicella zoster virus. So the size in the past was a monitor of 0.5 to 1 centimeter in diameter, umbilical rash, and they had the numbers of these rashes were huge in most of the cases. But in the recent study, which was done by Patel et al., published in Lancet and also in NAGM, they demonstrated that they had more than 500 cases, and they demonstrate that typical lesions were observed in 197, but there was a 2 to 10 people where there were 100, some odd numbers where the lesions were 2 to 10, and even there was just one lesion in some of the cases there was observed. There was also, there is a significant change in presentation of number of sites. In many cases, there was only one site where lesion or blister were present, and the prominent sites were now seen genitals, anus, or perianal area, and also the oropharyngeal. But in the past, the presentation was very different, which we have seen here in the earlier picture. So when we talk about the differential diagnosis with the monkeypox, we need to be prepared for not only chickenpox, measles, but in India, we also saw a huge outbreak of hand, foot, mouth disease, which is enterovirus. And that also the main reason, because after 3 years, school has opened, and now we have very small children population who never exposed to any disease or virus, and we have a very susceptible population. And we saw a huge number of cases happening across the India, and I'm sure the same scenario may be in other countries too. With this, we also need to rule out some of the bacterial skin infections, rickettsia pox, scabies, and also molluscum contagiosum, which is also have similar kind of presentation and get confusion. So this is a picture of HMF, many cases presented which HFMD created kind of panic in the state, and the samples were referred for testing. Even we also saw VZB cases which presented with a very severe kind of presentation and confused with the monkeypox. So if we talk about the monkeypox in India, we have screened around 311 suspected cases. Out of that, 18 turned to be monkeypox positive, 25 turned varicella zoster positive, and 10 enteroviruses. Out of these cases, 11 are male and 7 are female. So the theory which was given men to men sex and affecting mainly male is not actually happening. The females are also having positivity now, not only in India, but also in rest of the part of the world, where now not only the females, but pediatric population are also showing positivity for monkeypox. And which is obvious, because if they are in a very close contact with the parents and infected individual, there is a most likely they'll get infected. From India, only 2 states have reported the case. The first is Kerala. Kerala has reported 6 positive cases, and all of these cases are resident from Kerala, but they have travel history from UAE, and within the same week they were detected positive with the monkeypox. So mostly they're all coming with a transmission from UAE bringing to India. The cases from New Delhi, 12 cases has been reported. Out of these, 1 case is Indian, and 11 cases are having the origin from Nigeria, and they don't have any recent travel history, but in the past 3 months, 6 months, 1 month prior, they have come back from Nigeria. So this is the scenario here. When we detect the first case, we had 3 different real-time PCR method for orthopox, monkeypox, and also differentiation of West African and Congo strain. But now we have developed one tube test where you can identify all these in one single tube, and the test and process become very fast. So if we talk about the timeline of detection of monkeypox cases in India, of total 18 cases, the cases started on 14th July, and then slowly the cases coming slowly, but they are coming every week. Cases have been reported. We see some concentration during the month of actually in the first week of the August, and this is a scenario where we have also, there is a difference in PODs when we have detected the cases. The maximum number of the cases were detected at 5th post-onset day, and 5 cases. The mean age of these cases are 29 years, and all of them are non-vaccinated with the smallpox. There was 1 death reported, which also have the acute encephalitis symptoms from Kerala. The heterosexual contacts were reported by 10 cases, 6 cases denied for providing the history, and the death case has we could not reveal because the person died very quickly, and it was admitted for AES treatment, and later on it was confirmed for monkeypox virus. If we analyze all these 18 cases, we have seen the prominent symptoms which were shown by these cases: the sore throat, fatigue, lymphadenopathy, fever, and umbilicated vesiculopostular, which was present in almost all the cases. But with this, they also presented with back pain, chest pain, headache, and also dysuria, and genital swelling was also one of myalgia, fatigue. These were some of other symptoms presented in these cases. If we talk about the presentation of lesion, which I was mentioning that in the past, the huge number of lesions were reported when outbreak happened in West and Central Africa. But now there was 5 such cases. They have less than 20 lesions counts, and there were 7 cases where they have around 21 to 50 lesion counts. And there was only 5 cases which presented with 51 to 100. And there was 1 which we could not reveal the death case. There was not much identified. There was 1 genital lesion present in the case. So if we'll also look at how these lesions are presented in different parts. So the genitals and upper limb, the trunk, lower back, and face, these are the very prominent site. But also it was present in groin area, neck area, sole, and oral cavity, and scalp. So these are like distribution of the lesions presented in different parts. So these are the pictures of the first 2 cases from Kerala, returnees from UAE, where these lesions were identified. These are the pictures of the Delhi cases, where in the female, 2 of the female cases, where the lesions were presented in different body parts. And the details of these 2 cases and Delhi cases are already available on the web portal. If we look at the distribution of these these the symptoms and rashes. So the lymphadenopathy was one of the prominent feature present in almost all the cases. They had non-tender form and at present at multiple sites. And inguinals was the area where it was highly predominant. Cervicals were also showing these kind of presentations. So this is a distribution further to understand how these cases were presented. We also studied how long the virus secretion is happening in the individuals and when they are actually, because we say that once the crust get dry and then you can release the patient from the hospital, from the isolation ward. So we wanted to understand exactly how long virus is multiplying in the body and if the live virus is present or not. So we followed 5 of the cases. We followed actually all the cases, but I'm showing you data of 5 of the cases. And we could demonstrate that if you look at, we taken the samples at every 4th PID of these cases, including nasal throat swab and urine, serum, EDTA blood, lesions, fluid base, and also the crust. And the data demonstrated very distinctly that the lesion samples were having highest viremia and also highest duration. But at the same time, we also observed the urine sample was also very prominent sample, which was presented longer and can also be used as a diagnostic samples. The same time, we could also see the positivity in throats and nostril swab. And we realized importance of this case when the 5th case who died with the AES, because the death case happens, they could only take the sample of nasal swab and throat swab. And that could not only show the positivity, but also the genome could be retrieved and could be proven that the person was infected with monkeypox. So if we summarize the data of this study, then we could find monkeypox DNA from 5th POD to 24th POD, and the copy number of the viruses was also visible very well in the urine, TSNS samples and the lesion, different lesion samples. There was only one case where we could see the viral positivity in EDTA blood, and serum samples were negative in all the cases except one case with the high copy number of virus. So this is a kind of a graph which present how long which sample is having positivity. And recently there is one paper, yesterday only it has arrived in Lancet, and they have followed the different clinical sample of human to understand that how long the sample can be positivity, and the analysis and finding of the study also again say that the close skin context is the mainly cause of the transmission of the monkeypox in the current outbreak. So this is the case which I'm talking about, the death case from Kerala, which was a very young boy and immunocompetent male with no significant past medical history, admitted in unconscious state to a private hospital in Kerala following a single episode of acute onset generalized tonic seizures, and the clinical features, MRI finding, CSF picture, and EEG finding of these cases suggest encephalitis. And the only sample which was available was the OPS and PS, and they were found positive for monkeypox. The genomic sequences reveal a presence of A.2 lineage of clade 2B, which was actually, which we found in the later study that it is present in all of the cases which is present in India of the same lineage. So it means the cases which is imported from UAE, or I can say that UAE may be having the same strain circulation as well. So this is a presentation of this case where we could demonstrate the positivity of OPS and NPS. We could isolate the virus in viro cells, and on the second days itself, the cells started changing. We could observe the cytopathic effect, and it was isolated. Further susceptibility was studies in different 8 cell lines. The electron microscopic images was taken, and we could see very good pictures of pox, which is very typical for this particular family to see. We have developed also the validation protocol for any new PCR company or private firm if they would like to send for validation, which can be done here, and a proper panel was approved by a committee made by ICMR, which is available with us. We are also developing IgG ELISA to understand how not only the IgG ELISA, but the neutralization assay to understand, as in India, the people who are more than 45 years, mostly everybody is vaccinated with smallpox. So if they have some protections with the current monkeypox, and in that light, we are developing these two assays, we could see a good cross-reactivity with the sera of those people who has a immunization with smallpox. If we talk about the genome of these West African and Central African clade, which was present, and it was say that the Central African is present in Congo and those area, and West African was present in a specific area. So it was always claimed that the Central African clade is highly pathogenic and kill higher number of the people in compared to the West African clade. But in this recent scenario, we are not seeing the same case. The current outbreak when happened, then there was a lot of confusion how to label them by clade, and then WHO has come up with a new definition. So not to putting the Central Africa or kind of Congo basin, and also they have now categorized as clade 1, clade 2. The clade would consist the old strain prior to 2018, and the clade 2 is further divided into clade 2A and clade 2B, which is mainly taking a reference of all the sequences which is being done during this outbreak, which is going across the many countries. So this is a phylogenetic representation where you can see in the bottom, these are the blue one, which is actually presented from the endemic countries and called as a clade 1. Then clade 2 is divided into 2A and 2B, and a current outbreak is mainly happening because of the 2B. The outbreak, which started from UK in May, is spread many part of the country, and initially it was called as B1 lineage, which you can see here in the orange color, and further divided. B1 is now up to B.1.7. So it is mutating faster than it has happened in the past. Similarly, there is another clade which is called A. A is also further divided, and now it is labeled as A1, A.11, and so on. In India, we are finding A.2 clade and its sublineage, which is also further mutating. So definitely virus is playing very notorious in compared to the past, which we have seen. If we talk about the genomic sequences of lineage B1, which started spreading from Europe to other countries, it clustered with the sequences of 2018-19 and linked to the endemic countries, and which further divergent phylogenetically and reflect that there was some short of evolution has happened, and it shows 50 single nucleotide polymorphism mutation, which is far more actually higher than which is we consider for a DNA virus. In a DNA virus, basically we assume 1 to 2 substitution per genome per year, but now there is 46 SNPs has been detected, 24 non-synonymous and 18 synonymous, and for intergenic separating the outbreak virus from the reference sequence which was derived from 2018. There was 3 significant amino acid changes were also observed, which is happening in the immunogenic surface glycoprotein B21, and there is still a lot of studies going on to understand how these mutations are going to affect the transmission and other property of the virus. Initially, when we got the 4 sequences of KELA, 5 sequences of KELA, we did a quickly complete genome sequencing, and then we tried to look at where it is matching. So it was not matching with the current the strain which is circulating across the world, which is called B1. It's mentioned here in the green. The few representative strain are here, but it was matching with the strain from Nigeria, and the strain from imported cases happened in the USA in the current outbreak in Thailand. And then further we investigated with a larger pool of the sequences, including the sequences from KELA and from India. We found that actually they are forming a separate subcluster among the A clade, which is all of them are falling in clade 2B, which I just explained you, which carry all the outbreak strain of particular 22 strains, and that also have some of the sequences including USA, UK, Thailand, and they further divide, and all the KELA strain actually goes in A.2, 0.1, which is coming from UAE, but Delhi have two further bifurcations, and they are forming two sublineages. Some of them goes with KELA and some of them goes with the rest of the sequences. So these mutations and bifurcation indicate the virus is mutating fast. And the reason we know that because it is passaging from one host to another host. So the chances of mutation increase because the 30% population of monkeypox cases also HIV positive. So that also give opportunity for higher mutation as well. So these are the sequences here, which is further divided into sublineages 1, 2, 3, and India and KELA or Delhi and KELA sequences falling in sublineage 1 and 2. So, and when I say that the Delhi, it means most of them are coming from Nigerian resident who are having these infections. The further, when we analyze and look at the mutations and variant analysis in these sequences from Delhi and KELA, we found 25 additional ApoBAC3 mutations from the monkeypox strain circulating in India. Also, there was a substitution mutation which led to the stop gain at position which also recorded in gene OPZ176. The clot mutation, defining mutation was observed in C34472T in all the retrieved sequences from India, which is a specific characteristic of A2 lineage. So with the COVID and with the emerging many diseases, we have learned that timely identification and declaration, involvement of different stakeholders, enhancing the risk communication, strengthening capacity for source identification, contact tracing, quarantine, and isolation, improving the disease-specific guidelines, and also working on different vaccine and therapeutics, making self-reliant and rapid response team, capacity building, and also the enhancing public health networks, production of vaccine and logistics and supply is very much important, but same time, sensitization of the healthcare worker and community to non-stigmatizing this disease is very much important as well. With this, I thank my team who are mostly young people, females and males, and I also thank our former Director General, Professor Malam Bhargav, the Sri Rajesh Bhushanji, Secretary DHR, who is holding charge at the moment, Director Dr. Priya Abraham, my colleague from ICMR headquarters, Dr. Nivedita Gupta, ACD Chief, my colleague Dr. Reema, Dr. Anita, and Dr. Srilakshmi, who has worked all through the preparedness and doing this study, but this work cannot be completed with the great support from KELA Public Health, including from Health Minister to Principal Secretary, the Medical Education, IDSP officers, and different hospital authorities. Also, the Delhi, we have this hospital, LLGP hospital, which is authorized hospital for admission of the cases, and Dr. Vineet Rehlan and Dr. Suresh Kumar, director of this institute, has been a great support in conducting different studies to understand about the disease. And I thank all of you to listening. I thank the organization to invite me. I am very glad to meet all of you and feel very privileged and proud to be part of this community today. Thank you so much.
Thank you, Dr. Pragya Yadav. This was an excellent presentation. I would unmute everyone, and this is the time when we can ask question answers.
Saurabh.
Yes, Dr. Sajad.
Okay, thank you very much. It was excellent presentation, Pragya, Zabardast, and very informative. I have missed a few portion of your presentation, unfortunately. I would like to know that you have said that 18 cases have been detected in India. I want to know which part of the India, number one, what is the gender ratio, and thirdly, are they transmit locally or from the abroad? Thank you.
Yeah, so thank you so much for the question. Actually, so I just presented in one of the slide where we have shown that total 18 cases has presented from India that include only from 2 states, though the samples were screened from a huge number of the state, referrals were made, and the 30 functional laboratories are screening these samples whenever coming to them. We are also screening and confirming. We have set up a quality control. So from our country, the Kerala and New Delhi, these 2 states has reported the cases. Kerala has reported 6 cases. They are all imported from UAE. Delhi has reported 12 cases. 1 is Indian citizen and 11 are Nigerian citizens, and they have no travel history. So so some sort of outbreak is going on in Delhi in this particular community where the cases are being detected. Out of 18, 11 are male and 7 are female. No pediatric cases has been reported. From Kerala, one of the UAE returning, very young male was also found AES symptoms and died. And later on, it was confirmed as monkeypox case. I hope I answer your question.
Yes. One thing more. How can we protect ourselves from the monkeypox infection? Can we prepare? Can we say the general public to do something, preventive measure, adopt preventive measures to follow, to avoid this monkeypox? Number one, how can the government can play their role to protect the monkeypox?
So actually, WHO CDC has released a very good guideline. Indian government also released a guideline which actually emphasized that all the practices which we did for COVID, including the hand hygiene, mask practices, and if anybody is suspected to monkeypox, not to be very close. More important, if there is a case, it should be wise to put them in isolation, in negative isolation ward, and the people are doctors, nurses who are handling, they should have appropriate PPE, not getting infected, because recent some of the studies from US and also when we did in India, we found that when there is an infected patients, a large volume of the virus is secreted, and even we could isolate the virus from ward where the patients were admitted, including a different part of the ward. So that shows the huge number of the virus is secreted through the lesion roof and the fluid and all these things. So the area actually become very infectious. But for the normal public, I don't think there is a much fear because the number of cases are very lower. But at the same time, if people in practices of having the sex practices should be followed, safe use of the condom, but at the same time, there is another risk, the tip of the penis is not actually, if it is having the virus, it can still affect the close intimacy, close contacts, still touch. So I think these are the certain steps, if we follow, we can avoid certain. There was a lot of discussion about if you are taking care of the patient at home, which is happening in many countries. So you have to follow very a strong guideline of decontamination of the surface area, following the separate toilets and all those practices, which I think very well defined during the COVID as well. So
thank you very much. Thank you very much, Pragya. Thank you.
Dr. Hussain. Dr. Hussain, can you ask a question?
Saurabh, can I come in?
Yeah, please introduce yourself and ask question.
Okay, I'm Dr. Chakravarti. I'm a microbiologist and my field of work is in virology. Excellent presentation. I really enjoyed your presentation and you gave a total picture of starting from the history to the detection and immunization. Now, I would be interested in knowing 2 things. Number one, mode of transmission, okay? It is one of the STDs, they say, and as well as, is it droplet, is it aerosol? Because it's very important to have a proper hospital control measures for these things. Second thing is, you talked about genomic variations. So will the vaccines currently available, will they be effective against the genomic variant strains? Because these are just showing, I think, point mutations. So that's all I would like to ask.
So regarding the transmission, so yes, so all the patients should be definitely isolated in negative pressure isolation wards. The treating people should have at least N95 double gloves and also the disposable gowns, which was recommended during the COVID. The more importantly, if you say about the aerosols, so pox has been called aerosol transmitting disease. And I just take you to back the history of the first in the Birmingham when there was a smallpox outbreak because of the AHU virus transmitted and caused to the cameraman and the mother, they died. And because of that, the restriction of pox viruses was stored only in the containment facility of Russia and US. So yes, there could be, but the transmission in current outbreak is mainly happening in a very close context. Only those people are staying together in a very close contact, like the case which happened from human to dog. So it was because the area, room and everything is, and if you're very having the skin to skin close contact, either by sex, by kissing, or many methods which bring a lot of intimacy for a longer time. It cannot be just COVID, like you sit in front of somebody for a very short time and sneeze and cough can lead. It is not the case, but a very close intimacy only. And that is proven by different studies across the world where people have recorded number of the cases having, but yes, the having the sex is one of the main features was brought and again in this particular outbreak in the current scenario. Regarding the mutations and the vaccine which you have mentioned, so currently the CDC has come up with the data where they demonstrate that those people, there was some breakthrough were recorded, but still those people who has a vaccination, they were showing 14 times higher protection in compared to the non-vaccinated individual. So for sure, the existing vaccine is working for the monkeypox, and 85% efficacy has been observed with the vaccinia virus, existing vaccine for the monkeypox virus. The good thing is in pox, they have a very good cross-reactivity from one virus to another virus. So I think, yes, the current vaccine is definitely working, but many companies, pharmas are also trying to make a monkeypox specific vaccine because it is slowly established in the community and there will be a fear, and it will be wise to have the more vaccine for rest of the world who don't have the access for the current existing vaccine.
Dr.
Thank you
Hussain.
so much. Thank you so much.
Thank you.
Dr. Hussain from South Africa, are you back?
Yeah, good morning. Yeah, thank you, Saurabh. Let me take this opportunity to congratulate Dr. Kazi Wasik, CMAAO President 2022, and his team. And the scientific session was presented in a CMAAO meeting. It was excellent paper. Shahid Shamim was doing that. So you won't have any shortage in future to get a scientific paper to present in CMAAO. My question here to Dr. Yadav is an excellent evidence-based presentation. You mentioned HIV positive patient linked with the monkeypox. In South African study, those few cases we have, none of them was HIV positive. So can you highlight some more information on those HIV patients, where and how it happened? Thank you.
My apologies if I confuse you. So it is not about the South African studies, but the current outbreak which is going in Europe, US. So there is a paper has come up where they have presented that out of 500 odd cases, 30% cases were HIV positive. So, so I hope I clear my point here. Thank you.
No, thank you so much. Thank you.
Thank you, Dr. Hussain. Dr. Monica, you would like to add something or ask question?
Dr. Yadav, that was a fantastic presentation. I want to echo what's been said, that right from the history to the vaccine and everything in between, this is fantastic. There's a lot of concern now as we are getting further in with the number of infections and in terms of the fatalities, and you had published about the first Indian fatality in Kerala. I think now we're spending a little bit more time focusing on this particular infection, given that COVID is slightly receding as well. I also like the fact that you commented on the neurological complication in the presentation of the fatality. in India, and that is something that we cannot ignore whenever we see patients with acute neurological symptoms. So I would like to say again, thank you for all the points that you highlighted, and there was a lot of information that you presented to us that was of very high quality, and thank you again.
Thank
I
you.
think in the interest of time, we have already crossed the window. So I sincerely thank for the excellent knowledge which has come on this forum. And thank you, speaker. You're most welcome. Our team will contact you for a follow-up discussion. We would need a regular update like this. Dr. Wazik, yes?
Thank you, Saurabh. Thank you, Yadav. It was excellent presentation, fantastic. And here I would like to acknowledge that this weekly Zoom meeting was started by Dr. K.K. Agarwal, our ex-president, and keeping up the legacy. Saurabh is doing excellent job. And I would like to thank Monica especially because she joins us from US, and I don't know what the time is, must be 2 o'clock or 3 o'clock, early morning. So it is almost middle of the night, and she's regularly helping Saurabh in, keeping these weekly meetings on. And excellent presentations, excellent scientific work presented. And I think we must thank all the participants present here today. And Saurabh, I just wanted to know, we were thinking of doing it bi-monthly or 2 meetings in a month, because weekly meeting is definitely stress for you and for other people to join in. So you can always decide.
I will come back to you. Like, we can have a call offline for that.
Thank you everybody for joining in, and thank you all, and especially Dr. Yadav for excellent presentation today.
Thank you, Dr. Kazi, and thank you for your kind words. We really appreciate your acknowledgement for that. So with this note, we would like to end this session. Thank you so much once again, the speaker and all the countries been as a participant over here. We come forward over here, try to present all this knowledge, and thank you, everyone. We have no words to express for that. Thank you so much.
Thank you so much.
See you soon.
Bye.
Again.